I think people need to understand, like, when you have a country that has economic inequality, that has deep pockets of poverty, that has systemic racism, actually everyone loses out when you have a system that doesn't care for everybody.
This episode was brought to you by Alloy Health. I am so excited to welcome Dr. Uche Blackstock. She is a physician, health advocate, and CEO of Advancing Health Equity. She's also a New York Times bestselling author. Her book, Legacy, A Black Physician Reckons with Racism in Medicine, is a powerful and deeply personal exploration of racism in the American healthcare system.
Hi, Dr. Sharon. Thank you so much for having me.
I've been delighted to have this conversation. You and I have met in real life a couple of times before.
And hugged each other.
Yes, we have. You know how you just immediately recognize this, like, okay, game recognizes game here. So I want to get started with the essential question that I think most people don't really understand. And what exactly is health equity?
So it's interesting because I think for a lot of people, they've only started hearing about health equity, but the phenomenon has existed for a long time. And essentially, it's really the right and for each and every human being to live their fullest health potential. And I think you and I, as physicians, that's what we want for all of our patients.
And, I think that people confuse the terms equity and equality. We're not asking for equality. We're asking for fairness. I think we both use family stories to tell a larger story about the disparities that exist in the healthcare system. And you and I both lost our mothers while we were young. And I know that given your mother, who was also a physician, it couldn't have been easy for her raising twin daughters, no less. It's bad enough with one at a time, but two at a time has got to be some extra stress, I would say. So tell me a little bit about your mother.
Oh, thank you for asking, Dr. Sharon. She's a very kind and warm woman, and she actually grew up not far from where I am right now. I'm based in Brooklyn, New York, but under very different circumstances in the 1950s. Born into poverty, to a single mother, just had a really difficult life, but was the first person in her family to go to college, and then had a chemistry professor at Brooklyn College who saw her potential, encouraged her to apply to medical school. And she did, got into all her medical schools and ended up at Harvard Med. And I think what I learned the most from my mom is that, she could have gone anywhere after Harvard Med, but she came back and practiced in the same community that she grew up in for many, many years.
Given your mother's, obvious success, you yourself were an absolute superstar. You went to Harvard College and Harvard Medical School. You were certainly, no matter how you look at it, you were on the fast track to success. So your first job after you finished medical school in residency, you completed a residency in emergency room medicine, correct?
Mm-hmm.
And then you went to work at NYU.
Yes.
You were an associate professor there and the director of recruitment, inclusion, and retention. So, as I said, you're on the fast track to success. But something changed along the way. What was it?
Yeah, I think a few things. Yeah, I think from the outside, people probably looked at me and said, oh, wow, she's so successful. Look at her educational pedigree. Look at all the titles she has. But two things happened to me. One was actually when I went up for associate professor the first time, how that promotion got denied. And I was shocked because my department said I was a slam dunk. I had done everything I thought I had to do for that promotion. So that was really very disappointing. And then also around that same time, I had been appointed the position in our diversity affairs office as the director of recruitment, retention, and inclusion. And I really wasn't able to fully inhabit that role. I soon found out that that role was actually just a figurehead role. And so that was incredibly demoralizing experience for me because I'd been so excited to do that work because I knew it was very necessary. what I learned later on is that sometimes these roles are created because of what they may symbolize, but not necessarily because of what the work is that's actually done within the role, especially if you're not empowered in that role to have influence and to make progress, then nothing really happens. It's just a role.
And you decided, you obviously voted with your feet and you decided to leave. What did you have the next thing lined up for what you were going to do?
I did. And I was just talking about it. The next thing was my own consulting firm, right? My own consultancy, Advancing Health Equity, it turned 6 years old in March of this year. And I always call it my third baby because I have two little ones, 2 boys, and Advancing Health Equity is my third baby. So I said, I want to start my own consultancy around health equity, and address all of these issues like within healthcare, but I really want to do it my way in a very bold way. And so what I did was I decided when I left my academic job as associate professor, I worked part-time in urgent care centers in my former neighborhood in Brooklyn. And then the other half of the time I worked on building my company.
And there you were in an urgent care situation just right before COVID broke out. And is this the point at which you started to get sort of some national coverage about talking about the COVID epidemic?
Yeah, it was interesting because I saw my patients get browner and browner, and they were mostly essential workers and service workers. And I remember texting my sister and being like, saying, this is what I'm noticing. And also in my head saying, I am going to have to raise the alarm about this because even though we don't have any numbers yet, I think because of the vulnerabilities of our communities that we are going to be disproportionately impacted. We are going to be most impacted by this pandemic. I told myself also, Uche, you have to stay the course and stay in alignment. And what that was part of like ringing the alarm. So I wrote those op-eds, and then I became a medical contributor on a cable news station. And I said to myself, this is your moment. In the past moments, you have felt like you could not speak up because of the institutions that you were in, but this is your time. Your community needs you. And I think for many people watching TV, that was the first time many of them had seen a Black physician on TV giving out health advice.
Did you think that when people started sounding the alarm bells that it was disproportionately affecting communities of color, that it turned the tide in terms of the public sympathy and how we looked at COVID?
So I actually wrote an article about this last month because there's studies that came out around that time that showed that our white Americans, when they heard that COVID was impacting Americans of color, that some became less concerned about it. They thought it's not going to impact me.
I felt that, but it's one of those things where you don't know it's true, but you know it, I can't prove it, but I know it's true.
It's true.
But this all sort of every step led to the next step in your career and what you were doing, and leading to, of course, being a New York Times bestselling author. You and I our books came out relatively close in time. I think your book came out about a couple months before my book did. And we we talked about some of the same things and really used the same vehicles where we use family stories to tell the larger story about health. And whereas mine was more patient focused, what can you do? And yours was more, I'd say, what is the systemic issue? And what can we do to address some of these systemic issues? And is there a particular reason why you chose that lens to look at the medical system?
You mean from
the systemic point of view, I think it's
just because, I feel like I did use the stories in my book, the personal stories, to talk about the systemic, because I felt like what I hadn't ever formally learned in medical school, but what I learned very quickly in the pandemic is that if our systems are not functioning properly and are not equitable, then when there is a pandemic, right, the people that are most vulnerable are going to be the most impacted. So I think the pandemic showed for a lot of people for the first time, and others it didn't have to for the first time, but how deep those fissures were in our systems.
And I think that what has been lacking is the story that we tell about why these inequities exist. So can you give me a little bit of a very short version of why you think it existed to begin with and why it persists even, 150 years later?
It's interesting because I think, the book has, it's a memoir, but it also has history in it. And I thought to myself, like, how do I make history palatable for a broad audience of readers? And so that's why I interspersed the stories with it. But I think in general, I think it's very important for the listeners to understand that even, the field or the discipline of medicine itself is very much based on a system that was racist, a system that exploited enslaved Black people. So some people may have heard of, J. Marion Sims, the father of modern gynecology. He was the first president of the American Medical Association, which is the oldest and largest organization of physicians. But he made these really very important discoveries. So I'm sure maybe half the listeners, or more than half, when you go to get your OBGYN exam, there's a tool that's used called a vaginal speculum. So created that, but also created some surgical fixes, solutions to something that happens actually during childbirth, during traumatic childbirth, a type of fistula. And so, but he made these discoveries on enslaved Black women who could not give consent, right? They could not give permission. These were very painful surgeries. And even once local anesthetic had been described and was used by other surgeons and physicians, did not use it on those women. And those women really remained invisible for a very, very long time. And his statue was actually in front of the New York Academy of Medicine up until the late 2000 teens,
Right.
before it was taken down. But that's just one story. Like that's just one. So these discoveries that are deeply rooted in these myths that there's something very different about Black people and our bodies. And I think people like your listeners, our readers of our books need to understand the history, because when you understand the history, you also can understand why in 2025 we may still see why we see racial health inequities.
Welcome back to The Second Opinion. Today's segment is presented by Alloy Health. Aging happens to all of us, but that doesn't mean you have to live with hot flashes, brain fog, poor sleep, weight gain, or skin that suddenly feels like it belongs to someone else. These types of changes aren't random. They're hormonal. We know women out there have questions, so we're here to help answer some of those. We've received a number of listener questions about all things menopause, so I'm here to give you a second opinion. All right, here's a listener question. I'm 46 and I've started experiencing irregular periods, night sweats, brain fog, mood swings, and I keep hearing that's just aging. What should I really be paying attention to? Well, if you have all of those symptoms, it's not just aging, it's called perimenopause. I think that the first thing that everyone should pay attention to is to make sure that you're maintaining a healthy lifestyle. Make sure that you're getting adequate diet, adequate sleep, and you're exercising regularly. But even after you've done those things, you may still have these symptoms. And let me say this, you do not have to just put up with it. When there is a hormonal problem, which is what is happening in perimenopause, it's not just the lack of hormones, it's the fluctuation of hormones that may be causing these symptoms. And understand this can go on for years, and that's a long time to be miserable. So I would say if you are having any of these symptoms and you are bothered by them, then you should seek care. That is why we exist at Alloy Health. We make sure that women who are being put off or not being heard or listened to get the care that they need. Hormonal issues are best dealt with hormonal treatments. And that is what we do best at Alloy. If today's question made you think about your own symptoms, or if you're ready to finally get some answers, Alloy Health is a great place to start. Join the 95% of women who tried Alloy and saw relief in the first 2 weeks. Head to myalloy.com and tell them all about your symptoms, and you'll get a fully customized treatment plan. And you'll get $25 off your first order today when you use code TSO25. Head to myalloy.com and enter code TSO25 to get $25 off your first order. Well, this is the interesting thing that perplexes me even to this day. All right, so we know as long as we have been recording health outcomes, Black people have done worse all the time. We kind of even know why that is. It's not like we're still scratching our head as to why the outcomes are so poor. What exactly are the reasons that we have already identified why health outcomes are uniformly worse?
Right. And I think it's so important to people understand, even, how your educational level of attainment, your income, with the profession that you are, for us, for Black Americans, is not as protective for our health as it is for white Americans. And I think that those statistics, for me, emphasize how deeply rooted racism in all its forms is in our country. And that even when I think about, Arlene Geronimus, who termed the phenomenon weathering, of even sort of going through these chronic stressors of just dealing with even just everyday racism, which actually your jobs and your income don't always protect you from, that causes a wear and tear on our bodies that makes us predisposed to chronic diseases and premature death. That's one theory. But I think also when you actually even look at our neighborhoods, so even once there's some social and economic mobility, a lot of times in our neighborhoods, even if you were middle class, you may still be exposed to environmental toxins. You may not have all of the resources that maybe your white counterparts have in another neighborhood, because you may be living in a neighborhood that was formerly redlined. So, for example, that's how I grew up. I grew up in a neighborhood in Crown Heights, Brooklyn, that was a formerly redlined neighborhood. And I didn't realize this until I was older. But both my parents were professionals. We didn't have parks. We didn't have a grocery store. We always had to drive to another neighborhood. My parents still didn't feel comfortable sending us to the schools in our neighborhood. Yeah. And all of this because it was a formerly redlined neighborhood from the 1930s.
The thing that I think is most surprising to people is that even when you have access, as you mentioned earlier, that is not enough to protect you.
Yes.
And I think what we have to reckon with, and this is where your book comes in terms of how we have to address this in the medical system, because if it's constructed that way, we have to acknowledge the fact that a certain set of biases and a certain set of assumptions get made just when they see a person who looks a certain way, who walks into the examining room or the hospital.
Yes, absolutely. And, I write about in the book how even as a first-year medical student at Harvard, I had a misdiagnosis.
Yes. Please tell that story. Please tell that story.
And it really wasn't until I got much older that I reflected on that experience and said, oh, was it because I was a young Black woman? Most likely. I was a first-year medical student in the prime of my health, and I was in pharmacology class and started having very bad abdominal pain. And my twin sister ended up taking me to one of our teaching hospitals emergency departments. I was not feeling well, having lots of symptoms that I won't get into.
You're a Harvard medical student.
Right.
Listeners, do you hear that? Okay, now, all right, continue.
Yes.
I want to emphasize that point.
Went to the ER, was examined, told multiple times, like I didn't seem like I was in that much pain. Also questioned repeatedly about my sexual activity. And I will say, of course, I'm a young woman of childbearing age with abdominal pain. Yes, of course, you're going to ask them about their sexual history, but it sort of started bordering on this part where they didn't believe me when I was telling them. Yeah. And so it turns out I ended up being sent home, was not admitted to the hospital, ended up having to return to the ER 2 additional times over the course of the next few days. By the time I returned to my 3rd ER visit, my pain had just gotten so much worse. I was shaking. So I was having something, listeners call it Rigers, which meant that I had bacteria in my blood. I knew I was sick. And by the time I got back to the ER and had my CAT scan, my appendix had burst. And I was taken immediately to the operating room. I had to have an open surgery, open appendectomy, which is not typically done for an appendicitis. Usually it's laparoscopic, folks, like with little cameras. And then I ended up having, so I have a big scar on my abdomen now, but I also had complications, developed an abscess after that needed to be drained. I was out of school for about 4 weeks. And I remember at the first visit, my twin sister, Oni, saying to me, Uche, I think you have appendicitis. But both of us feeling, even as students, not confident enough to say anything. So you can imagine what most folks who don't have a medical background feel.
Right. And it's intimidating. So you think, oh, well, surely I'm a 2nd-year medical student. They must know way more than I do, right? But, the same thing I tell my patients, only you know how you feel.
Yes.
No, you are the expert of you.
Yes.
And the reason why that's so disheartening to hear, Uche, is because, as a young woman, that could have endangered your ability to have children.
I know.
With having a ruptured appendix. So, I mean, yes, I'm glad everything worked out, but it illustrates the point that we are often not seen, not heard, not believed. But this is what we're up against. And this is why I want to ask you now, so what are you doing with your company to help move that needle?
So one of the reasons why I founded Advancing Health Equity is because I said, I want to work with at the systems level. I want to work with hospitals. I want to work with health systems. I want to work with any kind of organizations whose work ultimately touches patients or the communities. And so we do a combination of things. So we do training. So yes, we do implicit bias trainings. We do cultural competency trainings, but we also go in and do organizational assessments. We talk to the clinicians. We talk to the patients. We do focus groups, interviews. We try to get as much feedback as possible. And often, sometimes these organizations, they need someone from outside to come in and say, hey, you are not doing things properly, and patients are feeling like they're not being listened to. Here are some strategies. Here are some processes that we can put in place to make sure that your patients are getting the best care possible. Because the fact is, I think every hospital or health system would say, yes, we want to make sure we're delivering quality care to everybody. And I don't think there is a clinician or physician out there who says, oh yeah, I don't want to treat patients. I want to treat patients differently. No, of course not. But the fact is that it's happening. So for example, in the ER that we worked with, they found that their Black patients were waiting 80 minutes longer to be admitted to the hospital or dispositioned for a doctor to make a decision about what was going to happen to them. So what did we do? Not only did we do trainings, but we actually said we have to operationalize this. We're going to put reminders in the EMR so that will pop up and say at 30 minutes, 60 minutes, say patient so-and-so is waiting for a bed. We're also going to make sure that everyone has a dashboard in real time so they see how they're performing compared to their colleagues. It's anonymous. And also it's something that, when they go for their yearly reviews with their chair, that is going to be part of a quality indicator. Is there a discrepancy in terms of, or disparity in terms of how long their patients of color are waiting? So these are things that are going to be important to us, and we're going to keep track of and intervene as needed.
And one of the things that keeps coming up, and I think that it is important to get culturally competent, sensitive care, but it's given where we are in today's world, where, probably 5% of physicians are African American.
Right.
That is too big of a burden to place
I agree.
solely on Black physicians, number one. And two, here's the other part of it, that we have to acknowledge the fact that this training that you're trying to get hospitals and the systems that you want implemented are not just for white doctors.
Right.
We trained in the same environment that everybody else did. So we have to, even as, Black physicians, we have to check sometimes our own biases because we've been taught certain things. I think that the one thing that I think is evident is that disparity is real. How do you think that in the current environment, where words like disparity and diversity and equity have become bad words, how is this making your job? Is it making your job more difficult?
Yes, Dr. Sharon. I would say that I almost get emotional you asking me about this because yes, I think we're in very troubling times where people actually want to erase what is fact or what is truth. And the fact is that if you have a colorblind system, it doesn't recognize or acknowledge when there are inequities. And so just by erasing data, for example, maternal mortality data that we're not going to be able to see, that's actually helped us within some systems improve outcomes because we had that data. By not having them, we're not able to provide the care that we need. So I think in this moment, what I ask is for health professionals, hospitals, health systems to, one, try to please be brave. Two, because ultimately you have to do what's best for your patients. And I think if anyone cares about their patients receiving quality care, they're going to recognize that you have to acknowledge those disparities, acknowledge where the disparities come from, how they may be perpetuated in your system, and what you can do about it. And so we may be using different terms and names and expressions, but the work remains the same.
I have another question that you may or may not be able to answer for me because, but it's disturbing. And that is, given what we know today, when are we going to stop observing disparities and start addressing them? And what do you think that we need to do, not just as an engaged electorate, but even in the medical profession, to really say, all right, yes, we know this. What are we going to do about it? And how do you think we should be better advocates for the healthcare system itself in addressing these inequities?
I mean, okay, so that's a big question, and I have some thoughts about it. I do think, and I think what people don't recognize is that when you look at many indicators of well-being within our country, whether it's life expectancy or maternal mortality, for everyone, like all racial and ethnic demographics, not just people of color, we actually are doing quite poorly when you compare us to other high-income countries. And I think people need to understand, like, when you have a country that has economic inequality, that has deep pockets of poverty, that has systemic racism, actually everyone loses out when you have a system that doesn't care for everybody. So a lot of these are policy decisions. So how are we going to take care of people after they give birth? How are we going to support people if they need to stay home with a sick parent, right? All of those policies actually make people healthier. I would love to see more physicians and other healthcare professionals take more of a role in advocacy, going to their legislators, whether it's local, even local and state level, sharing what their experiences are. They don't hear from us enough. And I know sometimes, like, maybe before we went to medical school, we were actually the ones with the loudest voices and protesting or whatever it is. But we have to remember, we really are our patients' advocates. And so, especially those of us, if we are working in marginalized and vulnerable communities, it's really up to us to share what's happening in our practice. So I would love to see more physicians involved in policy and advocacy.
That is exactly right. Because you know what? Nothing gets done unless you push for it. Because I think that we've all seen what inaction does, right. And it is nothing. Yes. It is just more of the same and more of the status quo. So yes, I do want to encourage all of our listeners to understand that this is a problem that affects all of us. It's not just about Black and brown people. We need to understand that it's all of us, not just some of us who benefit by addressing the health inequity. And we've talked about a lot of things, but I cannot have you walk away without saying, what is the hopeful side for all of this? What do you see on the horizon that you say, you know what, I'm beginning to see a little bit of daylight on?
Oh, well, actually, it's interesting. I think from these moments of great uncertainty that feel very unsettling, what I have been able to see so far is actually more community forming. I think oftentimes when we are feeling isolated or scary moments, we feel isolated. And what I'm seeing, actually, I know in certain pockets of medicine, I'm seeing people cross silos, cross disciplines, cross institutions, crossing states to really talk about, what are the innovative ways that we can keep doing this work, even in a moment where it seems like we may not be able to.
I have so enjoyed this conversation. I hope you come back so we can
yes, absolutely.
Have more. And I hope our listeners have learned something today.
Yes, I'm sure they have. And thank you so much for having me.
You are so welcome. And, as we end each episode, I want to give you the takeaways because, we talk a lot, but I want to make sure that you know what we really want you to know. And the first and most important thing is that healthcare disparities are not new. They're not new. They've always been around and they will continue to exist unless we do something to actively address them. And I think that the second most important thing is, despite all of the evidence to the contrary, we really do perpetuate this myth that race itself is the driving force for the poor outcomes. And we know in this country and all around the world that race is a social construct. It is not a biologic difference that determines one's health or their fate. And I think last but not least, we've really got to educate patients, because I think that we are beyond the time now where a patient should ever feel intimidated or unheard or unseen. And don't be afraid to speak up for yourself. Thank you for tuning in, and keep joining us each week as I break down complex medical issues and give you actionable advice on how to secure that second opinion.